condition, go. The patient's reactions will automatically adjust in real time based on what the students are doing. So you don't have to be sitting there saying, oh, I missed it, I didn't see Sandra do that, I have to. It will automatically all adjust itself. You can give it drugs, it will react accordingly. And based on this one physical model, we can represent different patients. So we can say this is a 21-year-old male who was just in a car accident. We can also say this is an 85-year-old smoker for 50 years who has heart disease, who's had one lung replaced or removed. We can set the patient up, present it to the students, explain what's happened or not explain, because in real life they come through the emergency door, you don't know what you're going to see. And what they'll do is they'll put the mannequin on a stretcher in a simulation center that looks like maybe a simulated emergency room, and they'll just bring it in. And now the team is there and they have to start asking questions. We have the ability to have, we can have audio.
In order to see unconscious or consciousness.
Exactly. So, you know, he could come in and they're not sure what's happening, and suddenly you put your hand on him, he's shaking right now, he's having a convulsion. Yeah, you can see he's shaking. So again, maybe he was shaking and then he stopped. We also have the ability to make them, for example, pee. So sometimes if somebody has a seizure, they may wet themselves. So we could bring this in through the emergency door. He's not shaking anymore, but his pants are wet. And as they start looking at his eyes, they're not reacting properly. Maybe that's the path. I'm not a clinician, but that's the way to also help determine. Maybe he had some kind of brain trauma and he just had a major seizure.
Losing the control of the body.
Exactly. So we also have the ability to give IV. So for nurses, somebody has to set up an IV line. They can do that on here. They can check vitals. His tongue, we can make his tongue swell. So in certain situations, it could be. So that maybe the patient's having trouble breathing. Well, part of the things you have to do is check the tongue and open the airway. Well, it's harder now to get the tube in the airway if the tongue's open.
First aid.
Exactly. So, you know, basic cardiac life support, advanced. So, and again, we have all different. We have children-sized models. We have female. We have male. We have for military that can be dragged through the mud. 185 pounds. You can, drop them out of the back of a transport. Just depends on the audience.
Are all the like motors and batteries in?
All
you don't have to plug it
self-contained.
in, so you don't have to plug it in,
So-
so you can literally just wheel it in.
Yes.
It does have a battery and it does run wirelessly, but we do usually keep it plugged in just for longer scenarios.
Right, but if you're
Yeah.
wheeling it in like
Oh,
an
yes,
emergency room,
absolutely.
you can do that. It's not like got
No, so let's
one cabinet behind you.
So Caesar, for example, the military use it. They'll have a scenario in a mock military training village where an IED has gone off. You'll have Caesar lying in the dirt, screaming for a medic, bleeding profusely from his leg or his arm. We have special effects kits that clients use to make them dress them up to look like different scenarios. But you can have the instructor hiding, 50 feet away behind a camouflage blind. He can have a little monitor we can have a remote camera watching what's happening. They don't know, well, they assume probably somebody's there, but they don't directly see him. He can be seeing all the outputs. He can change this on the fly if he wants. They may decide they have a small portable battlefield type patient monitor. They can connect it right there. They think they know what's happening, and now he throws a curveball in, changes the scenario. So it's often used wirelessly, but again, depends. Like the HPS is really only used in an operating room, a critical care scenario.
but no,
They're more static
I
in
like the
nature.
fact you can do it. Like,
Yes.
absolutely.
So, it actually raises a very interesting point. So one of the things I'm working on now is how can we work more with aviation? So whether it's training the cabin crews for some basic life support, because, the airlines gamble that 90% of the time there's going to be somebody on the plane who's a doctor or a nurse. When they call for a medical emergency, the chances are very likely that 9 out of 10 times there is somebody.
And that's an official statistic, 90%? Or?
Yeah, I just saw it online. It was a whole article about it because here in Montreal at McGill University, 2 emergency doctors created a course called Onboard Medical Emergencies, specifically for anybody in healthcare who travels a lot. Because even he, as an ER doc, the first time it happened to him, he panicked.
Right.
Because you're in a tight space, the body reacts differently at pressurized cabin of, 8,000, 10,000 feet. You have far less equipment available to you to treat the patient.
The staff doesn't know what to
The
do.
staff, so you probably don't have any supports, you're on your own. You may have 100 people in that part of the plane staring, watching, depending where it's going down. And now they're saying, Alain, we need an answer in the next 2 minutes. Do we dump fuel and return to ground?
Right.
So the cost of the airline, the pressure for that person, they developed a course